Welcome to our PCMH webinar. A couple reminders. Please mute your phone when you're not speaking, and please do not put your phone on hold. Our objectives for today are welcome, introductions, PCMH update with Dr. Kuo, a discussion on managing your practice without practice transformation vendor with Roger Williams from River City Pediatrics, and some time for questions and open mic. Support has been provided by Arkansas Medicaid, and joining us today is our Arkansas leadership and AAP staff. And now I will hand it back over to Dr. Kuo for a PCMH update.
Thanks, Kristen. The biggest update that I have for folks, there's really two issues. The first is that, of course, our 3-month validation, our 3-month deadline is coming up this week. The main issue, of course, is your making sure that your high priority beneficiaries are designated this year. The other part is that we had also been told that that PMPM payments would be coming earlier, sometime this month, and I actually have not yet asked if folks have received a payment. Have folks received? Do folks know that they have received their first quarter 2016 per member per month payment?
Yes, we've received ours. Okay,
great. If you have not received it, let us know. We will help you look into it. The two things that are due later this week are the designating your high priority beneficiaries and also entering your baseline measurements for your clinical quality metrics. Next slide, Kristen, please. Next slide. The other thing that I wanted to mention that we as a chapter are keeping our eye on is that you all have heard in the news that the special legislative session discussing the private option and various options becoming available to the state for further payment reform is to begin in the beginning of April. At this point, the legislative task force has worked with the consulting group, the Stephen Group. Their files and their findings and their recommendations are completely online. We've reviewed them. It also appears at this point that the focus of the session will largely not be on PCMH. There's been a lot of feedback to leave the PCMH program for Medicaid alone. We've also talked with our Blue Cross Blue Shield colleagues, and there is generally universal praise for the program, and there is not a whole lot of appetite to try to change it at this point, so that's all good. Granted, any number of things could happen in a special legislative session. We do want you to keep an eye on it. I will say, however, that regardless of what happens, the payment movement is all pretty much similar, regardless of whether it's here, whether it becomes a third-party situation, or whether it's in another state. And the issue is phasing ourselves out of fee-for-service and moving more towards a population-based payment system. And we are already in a little bit of that because you're getting paid through your upfront PMPMs on the number of kids that you care for, not the number of kids who come in, it's the number of kids you care for. And I think that is a good transition to our speaker for today, who we are very appreciative has brought an issue I think has been on many of our minds, which is managing your practice as we phase away from the practice transformation vendor support that has been provided to us through the first 2 years of the Arkansas Medicaid program. So Roger, I appreciate your thoughts and your time. I do have a number of thoughts, and we can engage in a dialogue on this issue, but I will definitely want you to have the floor first. Are there any questions from folks on the PCMH program, things that they've heard, things that are going on, experiences with the 24-month audits, experiences with the care plan audits? Okay, Roger, take it away.
Okay, thanks, Dennis. Yeah, I just really have a few thoughts, and then it really had just intended to open this up for discussion. So I'm not really, I don't have all the answers. So I'm just going to point out my observations. As it's already been mentioned, I think those of us who began in this program 2 years ago, the first adopters, we're coming to the end of our 24 months paid support from our vendors. Our clinic used Qualis Health, and I know also AFMC provides that same service. I don't have experience with AFMC on this particular matter because we've used Qualis, and I have to say we've received excellent support from them the past 2 years. I can't really say enough positive things about the things they've done for us. I mean, they provided quarterly workshops, face-to-face workshops, monthly webinars, sent out weekly or bi-weekly email updates throughout the process, and plus had the one-on-one assistance available. I think at this point, though, we all pretty much know and understand the basic principles of PCMH and how that model works in our practices, so I don't think we necessarily need that kind of education going forward. My primary concern is the communication going forward between Medicaid and the practices, because Medicaid has pretty much relied on the vendors, the Qualis and AFMC PCMH vendors, to provide that communication. There's been very little direct communication from Medicaid to us. And, I think everybody will agree that the PCMH thing for Arkansas Medicaid is still a work in progress. There's still changes, there's still new things happening. Just some recent examples. I mean, the care plan thing is still kind of a changing, it's been a moving target to know what is expected, in our care plans. I think maybe we're beginning to get a handle on that, but it's only just now. It's kind of finally coming around. But the new data extraction metrics, and there's going to be more of those in the future. I know those have been kind of problematic for some of the practices based on the EHRs that you have to get that data extracted. You might recall the recent flip-flop on the default pooling last fall, kind of a change in the policy at the last minute that caused a lot of confusion. The delayed the delayed per member per month payment that, frankly, I found out about that only through our vendor, our Qualis vendor. I mean, we did not hear about that from Medicaid. Also, just ongoing and analyzing and interpreting the quarterly pool reports going forward. I mean, each time we get those pool reports, it takes a little interpretation to figure out where we're going with those things and keeping our costs down. So again, I think I think communication is the key. I really don't think, I think Medicaid needs to develop some more interactive webinars. A lot of their webinars, when they do have them, coming from Medicaid, are more like information dumps, and they're really not interactive because we need that. And I think going forward, probably the Arkansas AAP chapter, these peer-to-peer, these monthly peer-to-peer webinars are going to be more important for us and a more important forum to get that information. So we may need to look at expanding this somehow, or providing a little more information and having some back and forth. So again, those are some of my thoughts. I know some of the, and I don't want to be negative, but I know typically a lot of times Medicaid defaults to the AFMC provider reps, and those folks do a great job, but they're spread pretty thin, and they're expected to kind of know a lot of stuff. And piling one more thing on them, I'm not sure how practical that's going to be. And a lot of times when you call Medicaid staff, it's hit or miss. If you try to call over to Medicaid and ask somebody, depending on who you get, they may not know what's going on. I mean, it's hit or miss sometimes when you get someone on the phone over there. So I guess that's pretty much my observations on this, and I'm happy to hear what other people think and what other people feel like they need going forward. I think for me, it's really, timely communication, what's coming down the pike, heads up on a policy change, and that kind of thing, so that we can be aware and be ready for things. So anyway, I'll throw it back open, Dennis, to you or anyone else.
Roger, thanks so much. I'm going to give you a couple of quick thoughts, and I definitely want to hear what folks have to say, and I'm sitting here, so I'm taking some notes. So the first is that I think that you've got it. I think you have hit the nail on the head on a number of issues, and I see this as more of a change than anything else, because I think that over the first 2 years that we were, as a state, we're left in a pretty solid place as far as practice transformation goes. You know, a lot of the other states around the country are really looking at the practices in Arkansas. And as far as what we're really building, we're changing the way we deliver medicine to a more family-centered, more population-based system, which, as we all know, takes a combination of reorienting your care teams, reorienting your data, putting in some infrastructure changes, and I think our vendors, both AFMC and Qualis, have done a great job at helping us along those lines. You know, the chapter is here, AFMC is here, the Arkansas Medical Society is here, and also I mentioned that we're also are not only working with Medicaid, but we're also looking at relationships with Blue Cross Blue Shield and the other private payers. And fortunately, the payers have all really committed, when my discussions with them have really committed to making sure that the requirements align as much as possible so that we're not trying to meet, 5 or 6 different sets of requirements. I think you're absolutely right in that the communication is going to be key, because some of this is still a work in progress. And I will speak as both a chapter representative and as well as the director of the effort here at Children's Hospital, is that my experience is that persistence in getting the answers you need is really the key, because as you've mentioned folks are working really hard, and in some cases the answers are not readily available. But with persistence and knowing the right folks, I do think that we can get the answers we need. And look at the number, and I appreciate the responsiveness of Arkansas Medicaid and changing a number of the ways that metrics were measured last year, just to give you a couple of examples. What I would advise is that, one is that I agree that Arkansas Medicaid, DHS, is still supporting our chapter to be the convener for these questions and issues. We are working on making sure that we get the same level of information that were provided to the vendors, something that Kristen, Amy, and I have followed up with, and that is something that needs to continue and can definitely get better. 2 is that I think these calls, as well as the use of the listserv, is going to be hugely important as well. And some of it is just sharing the ideas, such as the number of things that you mentioned. I think that a number of us have heard of the things like the delayed payments and the changes in the panels, but I don't think that was distributed evenly. The quarterly reports and the interpretations, the chapter has definitely been doing that for a number of practices, and we can continue to do that. I definitely want your ideas. I think we all definitely want to share these ideas, and I'm very, very grateful for you to have shared your thoughts, and I definitely want to hear what other folks are thinking. As I said, I'm sitting here taking notes. All right, I'm going to open it up to folks, and I'd like to get thoughts about how things are going and what you think that folks really need, because we're at a point where we are really looking to start to fly ourselves. Other folks, what's your experience has been in, what questions or concerns do you have going forward as we start to move away from the paid practice transformation vendors? So, for example, are you choosing to pay for a practice transformation vendor to continue support? Do you feel that you're well prepared? Do you feel like you need more from the chapter, the medical society, our AFMC practice reps, anyone else that we work with? Love to hear your thoughts.
This is Dr. Patton.
Hey, Dr. Patton.
Hey, Dr. Quinn. I did not start the PCMH program until about a year after many of you did. And so, in theory, I have another 9 months or so of support. So I'll stick with Qualis until they get out of the state on June 30th. But after that, I guess our only choice is AFMC for support until those 2 years end. You know, I agree 100% with what Roger said and would amen that. And really, the information dissemination from Medicaid is the challenge, and it's inversely related to the size of your practice. I mean, if you're a big Little Rock pediatric practice, you know, you may be getting a lot of that information and it's disseminated more efficiently because you have a full-time office manager. Even though Roger is the office manager, he has a small practice like we have, and I'm the office manager and still trying to see patients. So it's the thing about the persistence, you know, the comment you may have persist. I agree with that, but that's the challenge when you're in a small practice, is finding the time to be persistent, not the will. And so that continues to be a challenge the smaller the practice out in the state. The second thing is that when I've dealt with our AFMC reps, there's so much turnover. We've had 4 different AFMC reps in a year and a half in our area. And so not only do the people change, but the answers change. And one thing that I've appreciated about Qualis is the lack of turnover, the fact that if you ask one Qualis rep a question, another Qualis rep the same question, you uniformly get almost the same answer. And that's not true with the AFMC reps. I've gone to the big state AFMC meetings, and I will end up kind of going around the room because someone will refer me to someone else in the room, and they'll say, well, go over here and ask them. And, you know, so it's very frustrating that Medicaid does not realize the burden that they've placed on small practices by not having efficient, effective, and accurate communication with especially the smaller practices. So, yeah, I'm glad the AAP and you have done such a good job of disseminating that information because without it, we'd be lost. But I'm very worried that with loss of practice support, that even though I understand the concept, that many of the changes coming down the pike, since it's a work in progress, small practices will be late to the game and therefore not as likely to meet some of the changing metrics and changing goals. So I have several of those concerns in addition to what Roger voiced.
Kurt, and also Roger and others, in particular, this is really directed also to the smaller practices. I'm interested in your thoughts about whether you have about the infrastructure, and I'm thinking about partly your personnel, you know, the HR time, partly the EHR infrastructure to be able to meet the metrics, because and what I mean by meeting the metrics is like the clinical quality measures, for example. You know, as we move towards population-based payments, we will be moving more towards the quality, being paid based on the quality of the data that are being extracted out of our claims and our EHRs. How prepared do you think y'all are? And this is actually not just a small practice question. This is an everyone question. But I think that is, you know, that's a phase that we're moving into. Like, I think that I think what folks have really worked on in the last 2 years has been the culture, the team-based care. There's been a lot of great stuff on there, but now we're also looking at basic hardware upgrades and the ability to be able to produce good data. What are folks' thoughts on that? Do we feel prepared? What do we need to do more in that area?
Hi, Dennis. This is Warren Scott. Can you hear me okay?
Yes, Warren. Good to hear from you.
Yeah, same here. Okay, so I'll speak for a slightly larger practice. We have the same struggles. I mean, as far as EHR competency, one of the reasons we changed our EHR just about last year at this time was because we couldn't get our previous vendor to work up PCMH visit template to the satisfaction of Medicaid. Well, we've got that going a little. We passed the last audit as opposed to the previous one, and it's a matter of just our keeping up with right now the parameters set out each quarter. But that has worked a little better. We have, for a size practice that we have, 2 full-time nurses who do a really good job being accountable to those high priority patients and populating as much of that template that when they come in for their PCMH every 6-month visits as is possible ahead of time. So it makes it a little more doable for us. But boy, it took some organization and a lot of ongoing just keeping up with it. So it is labor intensive. I think we're maintaining things under budget, but it goes to speak that the PMPM money that we get, most of that really is going, that's not profit, that's going to working on getting this running. As to Qualis, they priced us a couple of levels of support for the coming year. I don't know if they'll do that each year, but so we bought into Qualis at a slightly lesser level. They're going to continue to, so it is possible to continue with a vendor to continue to coach with you and to look at their pricing for that. We thought we continued to need that oversight. We've been comfortable with them for a good while. I hope that helps.
Yeah, Warren, thank you. That's very helpful. And you know, Medicaid and the payers have always told us that the profit or our lost revenue, so to speak, or the profit is to the practice is really supposed to come from shared savings, and that the PMPM payments are being used specifically for structure. But I do find it always a challenge to make sure that the folks the dollars that we get for PMPM are being used to make patient care better and not to meet the simply to meet the needs of a program. And I do believe that all of our payer colleagues would say the same thing, and that is a challenge for all of us. I'm aware that that anyone could use the funds if they feel that the funds are available for that purpose to be able to purchase, to purchase practice transformation vendor services, and that is an option. We are running close to time. I wanted to know if there were other comments that folks want to chime in on, and I definitely want to continue this discussion. Kristen, Amy, and I are talk every Wednesday morning, and Kristen has regular meetings with the Medicaid folks, and I think that this is they want to hear this kind of feedback, and the Blues want to hear this kind of feedback because all of us want this to work. Other comments or questions?
Dan, this is Kurt Patton. I have another question on another subject. Sure. Right before Roger started talking, you said something about the Arkansas Works program and the legislative presentation.
Yes.
You know, my main source of information for this has been the paper, and so I'm a little worried about one provision that I'm sure it's non-negotiable at this point, but I never heard anyone really talk about it, and it's the governor's proposal to get rid of retroactive eligibility. And I think this unduly impacts pediatricians because I don't know what you guys are doing, but at least in my practice where most of my new babies are delivered across the street, and with the delay in the Medicaid software, we're not getting a Medicaid number on most of these kids in some counties, notably ours, till they're 3 and 4 months old. And so if a family member doesn't apply at birth, but then let's say applies at 6 weeks, then we're basically going to be seeing them until 6 weeks for free because
so we are
have eligibility as understand.
Yeah, I'm aware of that provision. We're not obviously not for that provision. I believe that applies to the kids in the expanded Medicaid and not the traditional Medicaid, because traditional Medicaid is separate. But it is something we are watching. That is not something that we're personally supporting. But I think, and I may be wrong on this, and I will, we can go and we can verify that is you know, that is the part of the expanded Medicaid. If I'm wrong about that, I will also come back and let you know.
Okay, that sounds great. And it's kind of related to that. You know, a lot of practice will not see these kids when they're born for the 2-week checkup or the 6-week checkup because they don't have their Medicaid numbers yet. But then, since the family's default is the emergency room, it's sort of one of those catch-22s where if you don't see them, you're already entering the PCMH phase with increased costs on that individual patient. And I've asked they see this, and they still don't have a good answer for me.
Yeah, no, I'm in agreement.
Yeah.
Okay, thank you. All right, folks, it's 1:15. We're going to draw this to a close. Please call or email us with any additional questions. Thank you all for a great discussion, and we'll be back at you next month, but please give us a call or give us a yell if any questions or feedback in the meantime. Thanks, everybody.